Welcome back, everyone. Today we're going to talk about the concept of neoplasia, which is really new growth. That's what it means, new cell growth. This section is going to discuss tumor formation. Not all tumors are dangerous for survival. There are some tumors that are considered benign tumors, which generally don't cause any kind of life-threatening events. Usually they still can. And then there are some tumors that are considered malignant, which tend to be under the category of cancers. We're going to start this section just by briefly discussing the cell cycle review. One of the things that's very important about cancers is to understand how there are some disruptions of the cell cycle. And a lot of times cancers and even some neoplasias have dysfunction in the regulation of the division of cells. So when we talk about the cell cycle, there are several phases to the cell cycle. There's G1 phase, or sometimes it's called the gap phase 1. This is the moment in time where there's growth of cellular components. RNA is going to be produced, proteins are going to be produced, and the cell's going to grow. During the S phase, there's DNA replication. So it's the synthesis phase. And then there's another gap phase, and we call this G phase, gap phase 2 or G2. This is where all the enzymes and proteins that are required for mitosis are going to be produced. And then finally, we have mitosis, which consists of prophase, metaphase, anaphase, and telophase. Cytokinesis is sort of a separate thing on its own where the two cells split. And then this continues and continues and continues. There are checkpoints throughout to make sure that there isn't any significant damage to the DNA, to make sure that all the chromosomes are lined up. And so there's a checkpoint between gap phase 1 and the S. So it's called the G1S checkpoint. Monitors whether the DNA if there's any damage, it repairs it before replication can occur. And then there is the G2M checkpoint that prevents entry into mitosis if there's any DNA replication that isn't complete. There's also a spindle checkpoint within mitosis to make sure that all the chromosomes are lined up along the center during metaphase and that there aren't any straggler chromosomes. Those are the three major checkpoints. We run into problems when there are issues at these checkpoints, when it fails to stop cell replication, even though there might be an error or there might be something wrong. The concept of cell differentiation is also very important. It's the process by which cells become increasingly more specialized. The cells of our body sort of start with a stem cell, and that stem cell has to divide. When that stem cell divides, it divides into another stem cell so that you can create more cells that come down the line, and another cell called a progenitor cell. And the point of this section here is just to show that with each division of this cell, they become more and more and more specialized, and they become different from each other. So this pink circle is the first generation, and that splits and turns into these orange-like ovals, and then the cell will change again and become this sort of octagonal shape, then a square shape. It's not that the cells are actually that shape, but they become different from each other. And each type of cell throughout the divisions is going to serve a particular purpose. And so each type of cell is going to have features that distinguish it from each other. In other words, they can be differentiated from each other. So when we talk about differentiated cells, it means that the cells serve a particular purpose with features that distinguish them from each other. Neoplasia specifically means new growth of cells. Any kind of new growth is called a neoplasm. They tend to increase in size and continue to grow even after the stimulus that caused their growth initially ceases. So it's sort of an unregulated growth in some capacity. We describe neoplasias as usually a collection or mass of cells that arises because of an overgrowth. We call that a tumor. Tumors don't have to be cancerous. Tumors can be non-cancerous. And we have a separate way to describe the how harmful a tumor will be. And so we can describe a tumor as being benign, which is usually not harmful to survival. That's not always the case, but it's usually the case, compared to malignant tumors that frequently cause suffering and death if it's left untreated. We usually call these cancerous tumors. They tend to destroy the nearby tissue, they tend to invade the surrounding tissue, and they tend to grow very rapidly. Usually when we look at benign tumors, they contain relatively well-differentiated cells, meaning that if we were to look at the cells of a benign tumor under the microscope, we'd be able to figure out exactly what tissue it came from. They have the specific features of the tissue. Malignant tumors can be either or. They can be well-differentiated cells, or it could be cells, when you look at them under the microscope, you really have no idea where they came from. And they don't have any specific features of a particular tissue. We call those poorly differentiated cells. So when we talk about neoplasms, we're talking about dysfunction in cell growth. And the question is, how can cell growth become unregulated? There's really a couple of ways that it can happen. Normally, when we have cells divide, they only divide when they're told to do so by growth factors. So there'll be a particular substance that's going to bind to the outside of the cell. It's going to be on a particular receptor that's going to lead to there be a cascade of events that happens within the cell. This growth factor could be a specific growth factor. It could be a hormone. It could be a number of molecules. But either way, it's going to lead to there be a change in the intracellular processes. It's going to cause there to be gene transcription, translation, and then protein formation to allow the cell to grow. So it attaches to receptors on the cell membrane. They're often G protein coupled receptors. This will turn on enzymes that will lead to second messenger systems, and it's going to cause there to be increased protein production within the cell. Cancers can actually gain mutations in any of these pathways. So there can be a problem with maybe the growth factor not being able to detach itself from the receptor, or maybe the receptor is always turned on whether there's a growth factor or not, or maybe some of these enzymes are always turned on whether there's a growth factor or not. You can imagine that if there's unregulated cell growth, you're going to get growth of new tissue that is going to go unchecked, and it's going to be constitutive, meaning that it never gets shut off. So there's two types of genes that are very important in preventing this type of thing from happening. One of these types of genes are called tumor suppressor genes. Usually they're a part of the checkpoints within the cell cycle, and the checkpoints will stop the division of any kind of mutated cells. They keep most mutations from developing into cancerous tumors by killing off cells that have specific mutations that are harmful. And if you kill off that cell, it will, in other words, suppress a tumor that might be able to develop. The problem comes if you develop mutations in some of the proteins and substances that try to protect against unregulated cell growth. So the substances at the checkpoints, there are these things called cyclins, cyclin-dependent kinases, cyclin inhibitors. One of them is called P53. These substances are going to stop the cell cycle if there's a problem. If you have a mutation in some of these cyclins, or the cyclin-dependent kinases, or the cyclin inhibitors, you won't be able to properly have a cell go through a checkpoint, and mutations are going to get by without destroying the cell or without even fixing them. So if you have any mutations in any of these particular substances that are going to keep most mutations out, then you're going to start to develop tumors. So if you have a mutation in a tumor suppressor gene, you can no longer suppress tumors, and you're going to get tumor formation. That's one way that you can actually get unregulated cell growth. Another way that you can get unregulated cell growth is through a mutation in what is referred to as a proto-oncogene. Proto-oncogenes are normal genes that code for normal proteins used in cell division. So these are going to code for things like growth factors and the growth factor receptors and the G protein coupled receptors, enzymes that are going to produce second messenger systems, genes that turn on and off these proteins. These are normal proteins. Proto-oncogenes are normal proteins. If there's a mutation in one of these proto-oncogenes, say that there's an unregulated amount of growth factor that's produced, or the growth factor receptor is always turned on whether there's a growth factor or not. These proto-oncogenes turn into the abnormal form of them. They turn into oncogenes. If you think about the term for a medical specialist who deals with cancers, they're called oncologists. Onco is the root word of this too. So if there's an oncogene present, it's a mutation in one of these proto-oncogenes, and you're going to get unregulated cell growth. So rather than proto-oncogenes will allow for growth, but only when a signal is present. If you have a mutation in a proto-oncogene, it leads to an unregulated amount of growth factor, unregulated amount of growth that happens in a cell because the signal that allows for growth is disrupted. Malignant neoplasms or cancers are will usually have an abnormality in growth factors, usually in proto-oncogenes, usually in tumor suppressor genes. All of these things can lead to cancer. And the process by which a cancer-causing agent causes normal cells to become cancer cells is something referred to as carcinogenesis. Carcino means cancer, genesis means new, so new cancer formation. There's a few steps in carcinogenesis. The first step is referred to as the initiation step. This is when you must have appropriate doses and exposure to appropriate doses of a particular substance called a carcinogen. Carcinogen is any substance that is known to cause cancer. After you're exposed to the carcinogen, there's going to be some sort of a promoting event. There's going to be an induction of unregulated or accelerated growth. So maybe there's going to be a mutation in the proto-oncogene that's going to lead to unregulated cell growth or unchecked mutations in the cells. So you divide, and one of the cells is normal, but the other cell is a mutated cell. And if that's in an oncogene, then this cell is going to divide whether it's told to divide or not. And there's going to be activation of the oncogenes, and there's going to be unregulated cell division that's going to happen and cell growth. Unfortunately, with each new generation of cells, because the growth is unregulated, there's going to be new mutations that are going to be added just by random chance alone. So with each new generation, it picks up more and more and more mutations that are associated with malignant cells. And because they're progressing to be more and more and more cancer-like, we refer to this stage as the progression stage. And this is the process by which tumor cells will acquire other malignant changes associated with cancers. And eventually there's a mass of cells that are all abnormal that are going to have unregulated growth. So there has to be an initiation event, a promoting event with either a mutation in a proto-oncogene or a mutation in a tumor suppressor gene, and then a progression event, whereby the unregulated growing cells are going to pick up more malignant changes in the tumors. Unfortunately, when we have a cancer, cancers tend to not stay where they are. They tend to invade the surrounding tissue. Initially, cancerous cells are going to be contained within the tissue. In fact, they probably just sit right on the basement membrane of an organ. When a cancer is just in place and it's not actually invaded the tissue yet, we say that it's in sight or in situ. So carcinoma in situ is just when the massive cancerous cells are sitting on the basement membrane. They haven't had time to spread yet. A cancer cell will eventually become capable of invading, because it's going to start to express surface adhesion molecules whereby these tumor cells are going to attach to receptors on the basement membrane of the organ that they're part of. These tumor cells are going to disrupt and invade this basement membrane. The way that they do that is that they're able to release proteolytic enzymes that make holes in the basement membrane. And eventually the holes are going to be so big that it's going to allow for some of the cancer cells to pass through. Even though this is a mass of cells, cancerous cells tend not to stick to each other as well. They tend to break apart from each other very easily. And when they do break apart, they can actually enter the deeper tissues and eventually actually make their way into a blood vessel where those cancerous cells can go and lodge themselves into distant parts of the body, or they enter the lymphatic system, whereby they go through the lymph flow and they eventually wind up in a lymph node. These two ways that cancers can spread, we refer to as being metastasizing or metastasis. That is a cancerous cell that has spread to other parts of the body. And there's two ways that it can do so, through the blood vessels or through the lymphatic system. I'm just going to write a couple of terms for you here. Two ways that cancerous cells can metastasize. One is through the blood. Sometimes we refer to this as hematogenous spread. And then the second way is through lymphatic system. And this will eventually end up in the lymph nodes. So when people have enlarged lymph nodes, and they also have a cancer, that enlargement of the lymph nodes are those tumor cells growing and making tumors in the lymph nodes as well. Metastasis can happen because cancerous cells tend to lose their cell-to-cell adhesion molecules. When they lose their cell-to-cell adhesion molecules, specific small pieces of the tumor can break off and can then go into the bloodstream, go into the lymphatic system. Not only do cancers have the ability to invade tissues and metastasize, there's also a lot of other hallmarks of cancer. There is a sustained angiogenesis. What that means is that there is going to be the creation of new blood vessels that will help supply the tumor with the nutrients it needs. Cancers tend to have limitless replicative potential, so there's no end to the amount of times they can divide. They tend to evade programmed cell death. They tend to have growth signals that allow them to be self-sufficient without having to have any part of the body tell them to grow. And they also tend to be insensitive to anti-growth signals. So even if you give these cells a substance to say stop growing, they won't respond to it. There are other hallmarks of cancer, but these are the 6 that are probably most important for your purposes. Cancers have a lot of causes. We know that some cancers are hereditary. So about 50 cancers that have been observed seem to run in families, but not all of them have genes that we have identified yet. However, there is a genetic predisposition for some cancers that has been proven. And probably the best known example are the BRCA genes. So BRCA1, BRCA2, and this stands for breast carcinoma 1 and 2. Individuals who inherit these particular genes have an 80% risk of developing breast cancer if they live to 85 years of age or later, which is significant. And it tends to be very high risk, high risk of developing breast cancer. Usually the breast cancer develops earlier. It can develop in men, and people could get multiple bouts of breast cancer with this heredity. It's not the only type of cancer that's associated with these genes. Depending on which gene you're talking about, there's also a risk of pancreatic cancer and prostate cancer and ovarian cancer, all associated with these BRCA genes. Certain chemicals are known to be carcinogenic. So a carcinogen is any agent, any substance that's capable of causing cancer. There's two types of carcinogens. There are the direct reacting agents. They don't need to be activated in the body to become a carcinogen. They're already a carcinogen. Compared to the indirect reacting agents that require your body to metabolically convert the carcinogen into a cancer-causing agent. Regardless of which type of carcinogen a person is exposed to, there is a dose-dependent aspect to the development of cancer and the risk of developing cancer. The higher the dose for the longer duration of time, the more likely a person is to develop cancer. You don't need to memorize this list of carcinogens. Just know that there is a list of carcinogens. There's a few that you probably know about. Asbestos, you probably have heard about. Asbestos increases risk of a particular type of cancer of the lining, most of the time of the lungs. Benzene is a well-known risk factor for the development of bladder cancer. Smoked foods and pickled foods tend to have a increased risk. Some of the substances in those foods tend to increase the risk of gastric cancer. So lots of different things are considered chemical carcinogens. Cigarette smoke is another one. We know that causes lung cancer. It's probably not limited to cigarette smoke. Any kind of inhaled smoke that a person is exposed to is probably also a carcinogen, but cigarette smoke is the most well-documented one. There are other types of things that can lead to cancer. So radiation can lead to cancer. We know that there are different types of radiation. There's a type of radiation called ionizing radiation, and ionizing radiation includes things like X-rays. This is one of the reasons why when you're in the dental office or if you need an X-ray for a particular part of the body, they cover the rest of you with lead so that you don't get ionizing radiation to your entire body. So that only the part of the body that needs to be X-rayed is exposed to the ionizing radiation. The type of cancer that a person gets based on radiation is really dependent on the gender of the person, as well as the amount of radiation, as well as the location of the body that the radiation has been, that the person has been exposed. One of the most common types of radiation that we're exposed to that can lead to cancer is UV light, the UV rays from the sun. They can be extremely dangerous and increase risk of skin cancer. Not only the most dangerous type of skin cancer called melanoma, but also the other forms of skin cancer, like a squamous cell carcinoma or a basal cell carcinoma. These are all things that are preventable if you reduce your exposure to UV light. So please wear sunscreen. Also sunglasses too. Sunglasses are very important to protect your eyes from the UV light. We know that UV light exposure to the eyes increases risk of cataracts, which is cloudiness of the lens. It also increases risk of macular degeneration, which is a very important part of the back of the eye that allows for very focused central vision. When that degenerates, you lose your central vision. So radiation is another cause of cancer. There are certain viruses that we know are considered oncogenic viruses, that they lead to cancer. The four that we know are definitely associated with cancer are human papillomavirus, leads to cervical cancer, throat cancer, and anal cancer. Hepatitis B will lead to liver cancer in some circumstances. The Epstein-Barr virus, which is the one that is responsible for mono, can lead to lymphomas and some types of leukemias. And there's a specific type of herpes virus called human herpes virus 8 that leads to a very, very rare type of soft tissue cancer called Kaposi's sarcoma. And that only is ever seen in individuals who have AIDS. In general, these are DNA viruses, and the DNA gets injected into the host cell, and then in some circumstances, it incorporates into the genome. And when it incorporates into the genome, it can lead to mutations. And that's probably why these are oncogenic. There's a way that we name neoplasms. Benign neoplasms are fairly easy to name. You just take the name of the tissue and you add the suffix oma to it. So if it's fat tissue, if it's a benign tumor of the fat tissue, we call it a lipoma, non-cancerous fat tissue. I'm just going to make a little note. I'll give a few more examples here of, there we go. Benign. So if you have a benign tumor of the bone, we call it an osteoma. If you have a benign tumor of the nerves, we call it a neuroma. If we have a benign tumor of the neuroma, lipoma, if of the connective tissue, it could be a fibroma. So lots of different examples. They just end in oma. Malignant neoplasms have a different naming system. If it's only the epithelial tissue, it's a cancer of the epithelial tissue, like the squamous cells of the skin. We name the tissue and then we end it with carcinoma. So if it's the squamous cells of the skin, we call it a squamous cell carcinoma. If it's a malignant neoplasm of the glandular tissue, any kind of gland whatsoever, we name the gland and then we add the ending adenocarcinoma. Adeno means gland and carcinoma means cancer. So if it's of the pancreas, we call it pancreatic adenocarcinoma. Okay. Anytime that we have any kind of cancer of the muscle, bone, fat, or any other kind of connective tissue, you name the tissue name with the ending sarcoma. So you'll be able to identify whether something is a malignant neoplasm of the connective tissue, muscle, fat, or bone, because it's going to end in sarcoma. Anytime you see the ending sarcoma, that's what it's a cancer of. If you see the ending adenocarcinoma, it's of glandular tissue. If you just see the ending carcinoma, it's of epithelial tissue. If you just see the ending oma, it's a benign neoplasm. But there are exceptions to this. There are lots of exceptions to this. There are some malignant neoplasms that don't follow these rules. So some of the exceptions would be something like a melanoma. This is a cancer of the melanocytes. It doesn't follow the same nomenclature. So you should know these exceptions. A cancer of the white blood cells. There's two of them. You can call it a lymphoma if it's of the lymphocytes. Or there's leukemia as well, cancer of the white blood cells. And that's in the blood usually, or of the bone marrow. There's myeloma. This is a cancer of the plasma cells. So there are lots of exceptions. Make sure that you know some of these exceptions, because I am going to ask you some of them on your test. I might say, which of the following is a benign neoplasm? And all of them are going to end in oma, and there's going to be an option that says, choose this if none of the above are accurately answer this question. And you may, and the word lymphoma might be there. So you should recognize that even though it just ends in OMA, it's still a malignant neoplasm. There are characteristics of benign neoplasms versus malignant neoplasms, and this is a really good chart to understand. So the cellular characteristics of benign versus malignant neoplasms, benign neoplasms tend to be well differentiated and resemble the cells of the tissues that they come from. Malignant ones tend to be more poorly differentiated or undifferentiated. They often bear little resemblance to the cells of the tissue origin. Not always, but often. The rate of growth of benign neoplasms tends to be slow, and in some circumstances it actually stops or regresses, actually gets smaller. Malignant neoplasms tend to grow a little bit more rapidly. This is not always true, but it usually is. The mode of growth of benign neoplasms, they tend to grow by expansion without actually invading the surrounding tissue. compared to malignant neoplasms that tend to grow by invading the surrounding tissue. They tend to send out little finger-like processes that infiltrate the surrounding tissue. If you think of the zodiac symbol Cancer, it's the crab with all the legs. That's what Cancer comes from. All those legs are all those little extensions that grow into the tissues. They can also be differentiated by the ability to metastasize. Benign tissues in general do not spread by metastasis, compared to malignant neoplasms that gain entry into the bloodstream through hematogenous spread or lymph tissue by the lymphatic system to spread to other parts of the body. None of these characteristics are hard and fast rules for every single type of benign versus malignant neoplasm, but it's a good general table to understand and to be able to tell the difference between benign and malignant neoplasms. There are a few words in here that we didn't really go through. I'm just going to show you here. Neoplasia. There's going to be a term called pleomorphic. These are all other definitions that we're going to have to talk about. And we're going to look at examples of them. We can generally categorize neoplasms, malignant neoplasms, into three general groups. One of them is called the solid tumors. This is usually initially confined to a particular organ, and then the tumor cells break off and they spread to distant parts of the body through the bloodstream or lymphatic tissue, and they will also invade the surrounding tissue as well. So those are solid tumors. That would be like a colon cancer or thyroid cancer or pancreatic cancer or lung cancer. These are all solid tumors. The second big grouping of types of cancers are hematologic cancers. These are within cells that are normally found in the blood or the lymphatic system. Because the blood and lymphatic system spreads throughout the body, is distributed all the way through, they're not initially confined to one part of the body because you have cells that circulate throughout. And this actually gives a clue as to maybe how we would treat these cancers. Solid tumors, there is a surgical component to it because it started in one organ and you can debulk that tumor. You can take as much of it as you can and you're going to get most of it. Hematologic cancers, even if there's large lymph nodes because there's cancerous cells in them, because the cancerous cells are going everywhere, removing those enlarged lymph nodes is not helpful because there are cancerous cells throughout the body. So in those circumstances, we will typically use things like chemotherapies to try to get rid of all the cancerous cells that actually go through the body. The third grouping of type of cancer is called a carcinoma in situ. This is a cancerous tumor that has not yet invaded the basement membrane of the tissue. If a carcinoma in situ is taken out surgically, there's very little chance of recurrence. Very, very, very little chance of recurrence because it hasn't invaded the surrounding tissue yet. Cancer cells show with it some major characteristics. The first one is something called aneplasia. Aneplasia just deals with the idea that cells have lost their differentiation. So if you look at this image at the bottom here, this larger picture, it's really hard to tell what tissue this came from. It doesn't really have any features that are identifiable for a particular tissue. Unless you're told where it came from, it's really hard to tell. Cancer cells or cancerous tumors also generally display the feature of being pleomorphic. And all that means is that there are various shapes and sizes of cells in anaplastic tissue. So if a tissue is anaplastic and the cells are of all different shapes and sizes, we would call those pleomorphic. It demonstrates pleomorphism. The image at the top, this is anaplastic tissue, and all the cells are all of these different sizes. There's some very tiny ones, there's some very large ones. These would be pleomorphic. Because cancers replicate so quickly, they go through mitosis extremely fast. Oftentimes, if you do a biopsy of a tissue that is cancerous, it will actually show cells that are going through mitosis. And we call these mitotic figures. In tissues that are not cancerous, it's actually quite rare to see even one mitotic figure. But in a cancerous tissue, you see many mitotic figures. You can actually tell the mitotic figures because they're a little bit darker than all of the other nuclei. So here's a nucleus here, normal nucleus. This is a mitotic figure. Look how much darker that mitotic figure is than the non-dividing nuclei. Same thing with this one. This one actually looks like the chromosomes are splitting and they're being pulled apart through anaphase. Another mitotic figure, much darker than the surrounding nucleus. Two more mitotic figures, much darker than the non-dividing cells. These are seen very commonly in cancerous biopsies, only rarely seen in normal tissues. The way that we diagnose cancer is really dependent on the location of the tumor. So in some circumstances, all you have to do is look and you can diagnose the cancer. So inspection, some skin cancers are like this. There are certain features of skin cancer that are this is definitely a skin cancer. We're going to remove it today. Sometimes you can't see because, just by looking at the person. And so sometimes you need a camera to go and look at various organs. This is especially true for gastrointestinal cancers, cancers of the esophagus, cancers of the stomach. You can't see those unless you put a camera down. And we call those endoscopic examinations. You can do urine tests. Cancerous cells tend to bleed. So if there's a tumor in the kidney or a tumor in the bladder, oftentimes there may be blood in the urine. You can do stool tests to look for blood. If there's a tumor in the colon, it will often bleed and there'll be blood in the stools. There are certain tumor markers that are, when there is a tumor present, there are proteins on the surface of those tumor cells that actually get released into the bloodstream. And so certain tumor markers are associated with various types of cancer. So you'll check for these tumor markers that are associated. You can do bone marrow tests. So if the cancer started in the bone marrow, you can do a bone marrow sample. This is usually to look for blood cancers. There are a couple of imaging techniques to look for tumors everywhere. So MRIs, CAT scans, but by far the only definitive way to make a diagnosis is to take a piece of that tumor and look at it under the microscope and look at the features of the cells. So those are biopsies. It's the only way to make a definitive diagnosis of cancer, a biopsy. All of these other methods can give you clues that there's a cancer, but the only way to get a true diagnosis is to take a biopsy. Couple of important features about cancer that are often talked about are the grade of cancer and the stage of cancer. The grade of cancer looks at the level of differentiation of the tissues and the level of anaplasia. Also looks at the number of mitotic figures. I don't expect you to memorize the grades of all different types of cancers because they're all different depending on what type of cancer you have. However, when we do grade something, it's on grade 1 to 4. And the only thing you need to know about this is that the increasing number means that there's an increasing amount of anaplasia or an increasing amount of de-differentiation or undifferentiation. So the worse a tissue looks from being able to identify it, the higher the grade of the cancer. The staging of a cancer is based on the extent of the disease, the extent of disease. So grade is based on how normal the cells look under the microscope. The stage is looking at how far it has spread. What is the extent of the disease? And this is really important in determining the treatment modalities. The way that we generally will stage a cancer, and you don't need to memorize any specific staging for any particular cancer. What I do want you to know is that it uses this system that's called the TNM system. It looks at the tumor size for T and whether the tumor has has spread locally, whether it has invaded the tissue and spread to the adjacent organs. So it looks at tumor size and local spread. For the N part of the TNM system, this stands for lymph nodes, and it looks at how many lymph nodes are actually, how many lymph nodes have cancer in them. And then the M looks at whether there has been any spread to distant parts of the body or metastasis. So we look at, to stage, we look at the tumor size and local spread, the number of lymph nodes, and whether it has metastasized or not. Stages of cancer are also based on a numbering system, stage 0 to stage 4. The higher the number, the more extensive the disease is. Usually it means that it has spread to other parts of the body. In general, we treat cancer based on the type of cancer, the location of the tumors, and the grade as well as the stage. Treatment usually involves one or more of the following therapies. The first three are probably the most commonly used ones. So surgery, if it's a solid tumor, to debulk the tumor. We can also use radiation therapy. This is specific high energy electromagnetic radiation that is beamed directly at where a tumor is, and it will usually try to shrink the tumor, sometimes to get rid of it altogether, but sometimes to just make a tumor smaller so that you can do surgery. Chemotherapy is the use of medications that are either given through the bloodstream or taken orally, and these are medications that are going to go throughout the body. These are important medications to use in individuals who have blood cancers or cancers of the lymph nodes that are where the cancer cells are spread throughout the body. But it's also used in instances where there is risk that cancerous cells have broken off from a solid tumor and spread to other parts of the body. And it tries to kill those cancer cells. Usually these types of medications, they act on very, very, very quick turnover cells, or in other words, cells that tend to divide very, very fast. We have normal cells that divide very, very fast, like the cells within our hair follicles. And so people with some chemotherapies tend to lose their hair because it kills off the cells that divide very fast to make hair. Some cancers are based on hormones and are helped by hormones. So if we block the hormones, some cancers are going to be sensitive to that. This is especially true in breast cancers and prostate cancers. And in some instances, there are immune system agents that are given to try to block aspects of the immune system that is causing problems with the cancer. The first three are probably the most important ones to understand: surgery, radiation, chemotherapy, one or more of the following. The last idea is the thought about prognosis of cancer. And this is the expected outcome of the cancer. And it really depends. It depends on the type of cancer. It depends on the stage, the grade, any kind of treatments that are used, whether the cancer has returned for a second time. And it also is dependent on individual patient factors. How healthy were they to begin with? Usually the prognosis of cancers follows a fairly standard way to describe it, and we use what is referred to as a 5-year survival rate, and it's quoted as a percentage. So in the literature, it looks at the percentage of individuals with a similar cancer who are alive after 5 years based on clinical studies. So when they try new treatments, they'll do a new 5-year survival, that maybe this treatment increased 5-year survival by X% compared to the previous treatments that were used years prior. So this 5-year survival rate is a very helpful way to describe whether the likelihood of survival after 5 years based on individuals with a similar cancer and similar treatment. We're going to leave it there for today. This will sort of conclude the introduction section to pathophysiology. From here, we're actually going to get into the more body system approach.